Hello and welcome to this week's episode of the Property Doctor podcast with me, your host, Dr. Andrew Threadgold. This week we're going up in the world because we've got a bona fide TV doctor on the podcast. Dr. Hussain Al-Zabaidi is a very well-known lifestyle medicine doctor. He started off as a GP and then became a portfolio GP as a partner in a practice down in Kenilworth, Warwickshire, the Coventry area, and now he heads up all sorts of think tanks and is well recognised by the Royal College for being an expert in lifestyle medicine. He's on TV shows such as This Morning, where he provides insight into all sorts of things, including the world of anti-obesity drugs, and also his take on what it takes to actually lead a healthier lifestyle. But not only that, he actually practices what he preaches, and if you follow him on his social media, you will see that every day he's out training, trying to compete in triathlons and getting his patients out walking. It's truly a wonderful story. So sit back as we talk about Hussain's story and how he ended up doing what he's doing, and also his opinion on lifestyle medicine and anti-obesity. And whilst I get talking about modern medicine and my feelings about it, and how sometimes doctors can be quite closed-minded when we work in the health system. But I'm spoiling it all. Let's not go into any of that. Let's get on with the show. So, without further ado, how are you doing, Hussain?
I'm doing really well. Thank you for having me, Andrew.
So, for those people that don't know you, and there may be one or two, but I'm sure there's not that many, could you give us a little brief background into yourself and where you are at the moment and how you got into this position?
Yeah, so I guess my kind of current focus at the moment is within lifestyle medicine and personalized care. And that sort of was probably born from about 8 to 9 years ago, a personal health scare. I'd gained a lot of weight during university, and the outcome was I had done a blood test, and I can't even remember for the life of me why the blood test was requested at the time. But long story short, it had identified some deranged LFTs, which liver function tests, which they did an ultrasound scan, and that demonstrated fat infiltration. So I was diagnosed with what's now termed MASLD, metabolically associated steatotic liver disease.
Mm.
And I'd realized that I'd gained like a good maybe 25 to 27 kilos from sort of the last time I'd weighed
Wow.
myself, which had been a long time because I was so kind of just focused on working and pushing myself academically and trying to achieve success, whatever I viewed that as at the time, that I had very much not been focusing on my own health and my own well-being and had been using various different things, whether it be food or other things, to kind of prop up a lifestyle that wasn't really sustainable. And so from that, I then really kind of reflected and looked at what could I do in my own health to make a difference. And yes, I lost a significant amount of weight, and yes, I reversed the fat infiltration. But more than that, that journey, what it taught me was how to prioritize things better in my life. So therefore I could live a life that I enjoyed more, because that's what I started to work out, that if I just focused on maybe adjusting my work hours, adjusting the kind of work that I did and the setting that it was, that not only helped me to lead healthier lifestyles to help reduce my weight, but it enabled me to just thrive more. I was enjoying life more, I was enjoying
Mm.
work more. And so now, when I sort of fast forward to this point, I went from being sort of a GP partner to being now I do part-time. I'm a GP locum, and I predominantly work in lifestyle medicine. So in the physical activity sector, either through education, research, as well as supporting public and commercial companies in terms of consultancy to help advise them from a lifestyle medicine angle.
Wow. So, a bit of a life event that took you down a different path.
Yeah, definitely. Like my family, unfortunately, have a very strong genetic risk as well as unfortunate lifestyle factors because my father had a similar problem and still unfortunately does. And nearly all my uncles and aunties, we have a combination of living with obesity as well as high blood pressure, high cholesterol, type 2 diabetes. We've got the full metabolic kind of
Yeah.
profile. And it just made me realize that a lot of kind of how I was leading my life was following the same patterns of my parents and my family. And like I could see why many of them did that. They were immigrants, and so their focus was purely on working hard, trying to build a kind of financial security and safety, and they weren't focusing on their own health.
Mm,
Unfortunately, now when I look at them kind of in their retirement years now, they're paying the price for that with, number of long-term conditions, poor quality of life, and that was a wake-up call for me because if in my mid-20s I was already, acquiring long-term conditions, I knew
mm,
that that wasn't a sustainable way to live. And it was funny, like everything that I'd learned in medical school hadn't equipped me with the knowledge to actually improve my lifestyle. I had very little training on physical activity, nutrition, sleep, all sorts.
mm.
And that I found surprising. And that's why it turned from a personal endeavor to a professional one, because I felt if I can get myself to this state, then how the hell is everyone else supposed to, support their own health and well-being without a medical degree and
Mm.
understanding of scientific data?
Yeah, for sure, absolutely. And I personally, I retired from medicine just over a year ago, and I've lost about 3 stone
Mm.
since then. And I think the job doesn't help. I mean, sedentary lifestyle never helps anything. But in the hospital medicine days, it's not so bad because you're quite active and you're out and about. But
Yeah.
I don't think the job helps the stress, the high cortisol levels. It doesn't help with sugar regulation and insulin resistance, and all the rest of it.
Yeah,
So
definitely.
I'm
With
sure
like a
everybody that's looking will look at you and see this really thin, athletic, super fit chap and wonder, first of all, what must you have looked like with 25
Yeah.
kilos extra on you? And second, how did you shift it?
Yeah, so like it was interesting because when I came back home from the scan result, because the sonographer sort of essentially told me kind of at the end of the scan, because I was asking him, I was like, I'm a doctor, what did you find? Um, like I hadn't even appreciated that I had really gained much weight. Like
Mm,
it wasn't something that really had triggered me. And so when I went home, I jumped on the scales, and that's when I sort of first realized that like I thought the scales were broken because they were miles away from the last time I had weighed myself, which was probably like 4 or 5 years ago. But then when I look back and when I was speaking to my girlfriend at the time, now wife, like I think I knew because I was already like I didn't want to get into photos. I'd
right.
always be the one taking the photo, find the excuse to not be in the photo. So clearly I wasn't happy with my body image. And the fact that my wife had to keep buying clothes for me should have triggered the thought that, oh, why do I keep needing new clothes? That probably should have triggered thoughts. But how did I shift it? Like it was slow to start off with because I tried a number of sort of short-term like fad fixes. You know
Yeah,
what I mean?
quick
Like
wins. Yeah.
specific diets and all sorts of kind of things. And it never works. And now looking at the evidence, I know why it doesn't work. And it wasn't my fault. It was just the whole process of trying to do something like that is not sustainable. But then eventually I then started to shift away from trying to lose weight to focus on actually, yes, I've gained a lot of weight, but I'm also unhappy. I'm also feeling completely burnt out from
Mm,
from work. I was just my life was revolved around just trying to function for work. Sunday, the latter half of the day was spent worrying about having to go in on Monday,
hmm.
and I just wasn't enjoying it. I wasn't enjoying life, and so therefore I go, okay, look, I can't seem to lose the weight. Let me just try and enjoy my life a bit more. And I realized that I had to make a big shift. Like, although I loved the partnership and I loved a lot of the partnership work, there was a lot about it that just wasn't conducive with my own health. And so I made the decision to step down. I also made the decision to cut back my hours and sessions. And it was difficult and challenging because it meant a huge pay cut. It
Mm,
meant, having to think about how am I going to manage the mortgage, the cost of the car, all the various things that
mm.
that was, coming out of my bank account every month. And I decided that I wanted to live what I call like a leaner life. So I just went through everything. I got the whole bank sheet out. I was like, okay, what am I spending money on? First and foremost, there were things on there that I didn't even realize I was still spending money on. Do you know what I mean?
Yeah, yeah,
Subscriptions, memberships that I was like, am I still a member of that?
yeah.
And I just went through it and was just crossing things off, going, okay, I need to get rid of that. I need to get rid of that. And I tried to just remove everything possible to start off with. And then I can then have a good long think about what I want to add in. So yeah, it was painful decisions, and they're not easy, and loads of things. Obviously, you lose out from certain enjoyments or access to. But I then started to realize, as soon as I removed a lot of that financial burden, it gave me the room and flexibility to start to stretch my mind to think about, well, what would you enjoy more of? You
Mm.
know, maybe another form of work, whether it be within healthcare or outside of it, what would bring that joy and that passion again? Because I wasn't work shy by any stretch.
Mm.
Like I'm very much, I love to work, but I just didn't feel like it was always giving me value, my previous role. And sometimes it felt more of a chore than a pleasure.
Mm, absolutely. I mean, the vast majority of doctors love to work, and I think that in the culture of the NHS, that's one of the things that we struggle with. That we always say yes without really thinking of our boundaries, and
Yeah.
further down the line, remuneration. We do stuff that doesn't get remunerated, especially as GP partners. You end up doing an awful lot of stuff that isn't accounted for, that just creeps into the rest of your life. And that's one of the biggest challenges of being a partner, isn't it? But so when you created this leaner life and then decided that you were going to think about yourself and where you wanted to go, how did you end up pursuing the path of lifestyle medicine? Because lifestyle medicine is it's not a traditional medical specialty. It's a more nouveau. It's a more modern medical
Mm.
thing that's actually gaining quite a lot of traction. And people like yourself are rightly promoting it because it's a very important thing that I think we will see more of as the years progress.
Yeah, like I sat down and I thought, what is it that I'm finding challenging about my current work? And I realized that I was becoming frustrated at the fact that in my 10-minute appointments, all I could do was sort of firefight and not really get to the root causes, not really support patients to understand the factors that are within their control. Because we often talk about the MDT and the multidisciplinary team, and let's say the GPs, the nurses, etc., etc. But we never really talk about the most important member of the MDT, which is the patient. You know,
Mm-hmm.
they're on the job 365 days a week. If they are not either motivated, interested, activated, or supported to do the best job that they can in that MDT, then you're not going to get good results. There's no point just writing a prescription and thinking that that's going to solve everything. So I realized that I was becoming disillusioned at the kind of whack-a-mole medicine that myself and a colleague of mine, Callum, used to describe. That we just focus on the biggest mole that's currently popping out and just knocking it down, rather than thinking about what's causing all of these holes and these moles to appear. And so I wanted to approach medicine differently. And the first thing I did was I set up a walk with the patients and the staff that would happen once a week on a
Wow.
Monday evening, and it still happens to this day. That is outside the practice. We meet up in the evening and we go for a walk, and it's now a walk and a power walk and a jog. So we have different groups for different intensities depending on ability or interest. And I immediately found so much pleasure and reward from leading those sessions. And I did that for free. Like that was not paid time. That was just something that I wanted to do because it meant a lot to me,
Mm.
that I could start to practice differently. And then that just sparked a whole kind of further interest where I wanted to develop that further. And I led a number of different projects where we incorporated different forms of physical activity, group consultations, which again, I initially started just doing for free, where we would have group sessions where patients, with different long-term conditions would come down and we would have discussions, shared discussions. It's not just education, me teaching, it's more me facilitating discussion around how they can take a lead in their health and help to guide and improve their health outcomes. And I submitted the work that I'd done to the Royal College of GPs because they had a link on their website to promote the Active Practice Charter, and they were asking for case studies of practices or networks that had done work to improve physical activity in their patients.
Mm.
And that got through to the college, and then they contacted me saying, "Wow, the work you've done is fantastic. We really want to sort of get you on to one of the conferences to talk about the work that you're doing." And I presented at the conference, and various different sort of senior leaders within the college then asked if I would join the team to help support and lead the lifestyle and physical activity team at the college because they have a clinical
Wow.
priority all focused around this. And so I said yes, and that was kind of my first sort of paid role doing something outside of sort of standard GP work.
Mm.
And that then really improved my confidence. I felt like I had more uh, sort of more confidence to approach my primary care network to say, the stuff that we're doing, these weekly walks, jogs, swims, spin classes, because we'd built up a whole menu of things that we're doing, plus the group consultations. you know, I feel that there should be funding to pay for my time, plus to build up a small team made up of social prescribers as well as health and well-being coaches to kind of lead and support on these projects. And luckily, they saw the benefit, and that's grown and evolved to kind of what we see today. And for anyone that wants to kind of find out more, if you just Google Leamington PCN lifestyle, you'll get to our webpage where it kind of has various videos and bits of information if you want to find out more. But
That's
short
wonderful.
story, it's helped to transform how we can support patients with lifestyle medicine within the NHS. That's kind of cost effective, but gets good outcomes.
That's absolutely phenomenal. Well done. And I think the Royal College gets a bit of a bad rep sometimes for being a bit stuffy and all the rest of it.
Mm.
I first heard about like the Royal College and its plans with lifestyle medicine. It must have been 10 years ago, and a friend of mine called Helen Garr. Don't know if you know Helen.
Yes, I don't know of her, but I know her, if you know, that makes sense.
Yeah, yeah. So Helen and I did our occupational medicine diploma at Birmingham together. And shortly after that, that must have been over 10 years ago. And very shortly after that, she got one of the jobs at the RCGP doing something around lifestyle.
Mm,
And that was all that time ago. So
brilliant.
yeah, and I thought, wow, that's a bit forward thinking for an organization that's supposed to be, gets a bit of a bad rep from GPs. But yeah,
Yeah, no,
that's
very much
phenomenal.
so. And in a way, we're kind of ahead of the curve for this 10-year plan that was published on Thursday because we've been really focusing on various different elements. So it's not just that we've got the team there, we've got projects like the Active Practice Charter and Park Run Practice, etc. But we also, last year, alongside three of my colleagues, we co-authored the extended role for a GP in lifestyle medicine. So on the
Mm,
college website, if people want to develop a career within that extended role, it outlines kind of the training that you got to do and the various different bits and bobs. And so it's fantastic to see a role that I kind of forged for myself those sort of 7, 8 years ago now is starting to become more formalized as we've got more and more interest to do it.
mm,
And yeah, and it kind of that builds confidence because as you slowly start to work outside of your normal routine and pathway, you start to realize how to frame what you're doing, how to communicate and network in order to build potential career opportunities. And from that, I've gone on to take on a number of teaching roles, for example, with Red Whale, GP Update.
right.
And from there also with the kind of projects that I'm doing, it got a lot of interest from local media, which then spread to kind of national media, and that's where I essentially got to the point where I do a lot of media work with the ITV and the BBC, all through kind of slowly building exposure through different outlets to try to promote lifestyle medicine and the
Mm.
benefits of it.
Yeah, yeah. So, but one of the my lines of inquiry, if you like, was so what I've got a phrase that my business partner has taken on. It's one of the things that I say all the time, and that's activity creates opportunity. It's a
Mm,
very entrepreneurial mindset thing that when you go and do something, you'd be amazed the stuff that comes off the back of it. So my line of inquiry was, did the stuff that you've just talked about end up with you having doors open somehow into the media? And obviously it did. So
100%. Like whenever I do webinars or education sessions, a common question often is like, how did you get, let's say, this role, like this morning role, or whatever that may
yeah,
be?
everybody will want to know that as if it's you
Exactly.
just
Yeah, yeah. They
apply.
want to know kind of how you got various different roles, and like, I wish I could tell them like you need to do one, two, three, but it's
Yeah.
not like that, as you say. Like it was just about just slowly building up the kind of the work, doing it to the best of your ability, and just as that approaches, an opportunity presents itself because of that work that you're doing. They see it, they think it's good, they want to collaborate with it in some way or collaborate with yourself. And so slowly, kind of, you build up that network and that knowledge. And when I think about the first media thing that I did, sort of national, it was on Channel 4's Steph Pack Lunch. And a researcher they were looking for a GP to jump onto the show, and she just Googled best GP in UK. Now, I'm not saying I'm not even close to that, but what that search did is it then pulled up a rewards, the GP National Rewards website, where I had
Right.
been nominated for a number of the projects that I had done. So I was on the shortlist. And my surname begins with an A. So she started at the top of this six-person shortlist. And so if we got rid of the Al and I was Z, I probably wouldn't be on this morning in various days. So yeah, it's a little bit of luck, but you can generate more luck based on just slowly building up that exposure and just picking the things that you want. And because not all the opportunities you're going to want to go down, but the more that you're able to create that activity, the more likely you are to get opportunities that you do like. And
Yeah.
so that's why I always try to recommend to people when you're doing projects like this, working in fields that you're passionate about, try to spread the message on things like LinkedIn. Don't just do it and not tell anyone. And
Mm.
it's not about, blowing your own trumpet. It's just about one, because I really want to inspire other clinicians to do the same,
Mm.
because I want other patients to be able to access these benefits, but also because it helps to generate more options down the line. And so my career and the kind of roles that I've done have evolved over the years as opportunities arise, and you slowly kind of put together the portfolio that you enjoy and that works for you.
Yeah, absolutely. I don't know on your opinion, but a lot of doctors wouldn't have even followed the opportunities that you've created for yourself. A lot of people have a very closed mindset. They're very, I will, I see my patients and this is my job. If something else happens, a lot of people won't acknowledge it or won't pursue it because they're very focused on what they're doing. And a lot of people actually have imposter syndrome. I'm not good enough.
Mm, yeah.
Um, so the fact that you had the right mindset is testament to you that, an opportunity, a door might have become ajar and you walk through it. A lot of people wouldn't have done that. And
Yeah, and for some, like, they enjoy just the classic GP work, and that's brilliant. And we need plenty of
we
those
need those
kind of
people.
people, which is good. I think, but a lot of people approach me and they're looking for something else, and they want to work with a career in lifestyle medicine similar to my own, and that's where I have to, like, be honest with them and say that, look, there aren't kind of jobs that you just apply for. You
Yeah.
can't just go to a website where it lists them all out and you can just select one. Unfortunately, that's not the case. So it is, as you say, it's difficult for them to shift their mentality to say that, well, they have to take some risks.
Yes.
So, for example, if I was still working kind of full time, just doing day-to-day work, you don't have the mental space or the energy to really dedicate enough time to these things. And if you did dedicate time, it's unlikely to be your best work because you're going to be fatigued and probably
Mm.
creativity squeezed out. So you have to be able to take that risk and understand that you're going to put in a lot of effort and you don't know if something's going to come out of it. You
Yeah.
may put in a lot of effort and nothing comes out of it. But
Yeah.
just from my experience, that if you put in enough effort and you focus on improving your skills and improving your knowledge and have patience as to how long it's going to take, things do come out of it. You just have to
Yeah.
have that kind of that delayed gratification when it comes to looking and exploring for alternative roles.
For sure. Absolutely. I mean, you're speaking my language. I speak quite often to junior doctors. I've got a little bit of a name as because obviously I've escaped the NHS, so I've got a little bit of popularity because of that, and I get asked to talk to junior doctors because even I mean, in my case, I'd got my CCT, and I was a career doctor.
Yeah.
Um, Long before I ever wanted to get out of medicine, but now people are thinking about getting out of medicine the minute they qualify,
Yeah.
which is a cultural thing, and don't need to go into all that. But so I get asked to speak now and again to doctors at various stages of their career, and I get a lot of messages across the social media platforms. How do I do what you're doing?
Mm.
And everybody wants, oh, you just do X, Y, and Z and you're out. Nobody wants to hear, well, I was doing 120 hours a week as a partner and as manager, as medical director of an out of hours service. And then I was still doing 30 viewings on houses a week and putting 29 offers in and then going doing renovations and refurbs, and it took years of that before I started to get anywhere.
Yeah.
Nobody wants to hear that bit.
Absolutely. Yeah. Just like when I had to explain that I worked all of those hours when I was a partner, let's say doing those other projects for free for about 18 months.
Yes.
So that was, at least on top of the work that I was doing as a partner, maybe 12 to 15 hours a week, just be doing unpaid work because what I wanted to do initially when I approached to say, look, could you fund this project? They were like, no. So I was like, well, if I'm going to get this across, I need to prove that's effective. So did it for that period of time for free and then did a service evaluation to demonstrate the health impacts that they were seeing and how that actually it was paying itself back through the various different targets that we were meeting and aligning up to what the KPIs were for the PCN. And so, yeah, people don't want to hear that bit, but all I'm going to say is that kind of transition period where you're having to sort of really push and strive for something, it will teach you so much, which you'll then be very grateful for once you find that balance. But you can't access that sort of promised land. You can't access it straight away. It has to be through a real kind of period of learning and stretching yourself, essentially. But
Mm.
doing so being patient at the same time. Because I think a lot of people think, okay, 3 months and 6 months, I'll be able to create a whole new career. Careers do not develop over 6 months. It took
No.
you, I don't know how many years to become, let's say, a GP or any other specialty in the first place. It won't happen over 6 months. It'll happen over longer than that. So you have to understand it's a bit like a clutch for me. Like as time went on, I slowly dropped a few sessions, but remained as partner. And then I got to sort of the point, the critical point where then I was like, okay, actually at this point you can't really do any less sessions and still be a partner, really. And so then you sort of drop down to salaried, and then I slowly then dropped down the sessions. So it was kind of like a bit of clutch control.
Yeah.
As time went on, I slowly pulled back from that element as I acquired more of the kind of components that I was looking forward to.
Yeah, yeah, for sure. Absolutely. Do you still locum back at the practice where you were a partner at, or do
Yeah,
you?
yeah, yeah, fair bit, yeah, and it's a
Yeah.
great practice, and that's the thing. Like, often people think that like it must have been an awful place to work, etc. It wasn't. Like, it's
Mm.
actually, I think, probably the best practice that I've ever worked at, and the team there are absolutely fantastic. It was just more the kind of work that I was doing. I just didn't feel I could help the patients as much as I could in that setting.
Mm.
In that sort of 10-minute consultation mode. The patients weren't expecting to get anything else but a prescription, and
Mm.
I didn't have any time to really be able to support the patient to tackle anything deeper. And so all the kind of lifestyle projects that I do within the NHS are still in the same primary care network that I was a partner at one of the practices at. So
Mm.
it's not that it was the place that was the problem. It was just the type of work I wasn't
Yeah.
finding rewarding. So I just changed the type of work.
Yeah, for sure. Yeah. Did you find it difficult, or did your partners um not make it difficult, but did they resist your slow exit?
No, they didn't resist. Like there was definitely disappointment, because like I was definitely the kind of person that always said yes to everything. I don't have kids, and so I was always like the most flexible to bail us out of problems. So if someone had to go pick up their kid from nursery or XYZ, it was always Hussein that would sort of step up and do the duty shift or whatever that may be. And there was definitely disappointment that I was going, and that was probably from both sides. But no, they were fantastic, and they enabled me to continue doing the elements that I enjoyed, and they saw that my kind of ethos had very much changed over the years, and that I
Mm.
wasn't getting the reward out of the core GP work as it is at the
Yeah.
moment. I say that because I'm hoping when I'm reviewing this 10-year plan, a lot of that what's in there are the things that I've been saying, and I'm sure thousands of other clinicians have been saying for years. So who knows as things change, if they do have actual material change in the kind of way that primary care is delivered, I could very much see myself starting to incorporate more of the kind of clinics, but those clinics being differently designed, so therefore patients actually have the the time and we have the time to appropriately treat people.
Yeah.
But yeah, no, they didn't. They were it's a fantastic partnership that was there, and I think a lot of them knew that I was becoming disillusioned with the kind of how it was being run.
Mm.
Not at the practice specifically, but just how the NHS primary care was being run. I didn't feel like it was doing the patients any good.
Yeah, for sure. Yeah, I mean, it's a completely different situation when I left. I think all my partners were burnt out and
Mm,
um, disillusioned. And when it got to the point where, and they knew I was going for a long time before I actually left, but by the time I got to the end, there was a little bit of crabs in bucket mentality. So for anybody that is listening or watching, if you've never seen it, have a Google of crabs in buckets, and as soon as a crab starts to crawl out of a bucket, the crabs beneath them pull them back down into the bucket. And it's this thing, this human behavior that you'll see in all walks of life. And as soon as I started getting out of medicine and I was able to leave, the attitude with my partners in my practice changed because they could see somebody was getting out and they weren't. Um, so it's just a part and parcel of the symptom of the NHS at the minute. But
yeah.
without dwelling on that, I'd like to ask you actually now that you're no longer a partner and you're more well versed in the breadth of medicine than perhaps we are when we're NHS GP partners. What do you think of the more modern approaches to things like weight loss, such as because I've seen you talk about GLP-1s and Ozempic and Monjaro and all this. What's your take on those medicines and where do you think the future lies for
Mm.
things like weight loss in
Yeah.
healthcare?
So, in terms of where the future lies, anti-obesity medicine is getting more funding than AI at the moment.
Is that right?
So that's your answer to where the future lies,
Okay.
because what we've got at the moment, like give it a few years, it will already be obsolete. It'll be like when sort of the laptop started coming out, and each year the chip sort of makes the previous year's chip pretty much redundant. In terms of kind of what are my thoughts about it, I think those living with obesity have been poorly served by healthcare and very much society and government for a long time.
Forever.
We know that there are strong genetic components that influence weight. They generally, it's around 140, 150 genes, which predominantly control your thermostat for appetite. So when you have that kind of genetic makeup in the population, and then you then have an environment where we're getting foods that are more and more natural, that are more calorie dense, that are designed to hit the maximum dopamine when you consume them. When you combine that biology with the current environment, the end result is increasing obesity rates,
Mm.
which is why when you go back to pictures of the beach in the 30s and 40s, it's a stark contrast to what we see now. And so it's clear that things need to change. Now, what needs to change? The environment, yes. And government needs to be very serious as to what it needs to do to provide a healthier, safer environment, because even that environment is not equally distributed, where areas of deprivation have far higher rates of fast food joints, gambling access, all the various unhealthy behaviors that we know leads overall to poor health. And they also have poorer access to the positive elements, whether that be parks, leisure centres, etc. So yeah, most of the work needs to come from policy and shifts in our environment. But until then, and given that unfortunately the way life is and the way business runs, that's unlikely to happen anytime soon or to any big degree. We have to be able to support our patients on reducing the weight, because obesity drives so many long-term conditions,
Mm.
whether they be metabolic conditions, anatomical, or mental health and behavioral. So these medications are a good tool only when used appropriately with the right patient, and it must be alongside the key pillars of lifestyle medicine. And that includes not just the nutrition and physical activity and things like that, but psychological support as well as support for the social determinants that we know are influenced with obesity. So I think these are going to be hopefully good tools, but do I feel that they're going to be applied correctly and ethically?
Hmm.
That's where I'm concerned.
They're
That's where
already
I'm
not.
concerned. I think from experience seeing how it's applied, let's say other medicines in other conditions in the past, it's going to be used like a silver bullet
Yeah.
and an expectation that it will fix things and things will get better. But we know from the evidence people will regain weight when they stop it. We know that if it's not done alongside physical activity and improved nutrition quality, then we're going to see increased rates of sarcopenia as well as nutritional deficiencies. So yeah, I think this. I don't think the problem is the medicine. I think the problem is how we're going to apply the medicine in our current medical model, where most clinicians have no idea how to effectively support patients from a physical activity, nutrition, sleep
Mm.
standpoint. So
Yeah.
that's where
Yeah.
my concern is.
Yeah, for sure. It's the reason that I kind of prefaced what I was saying with the now that you're not a GP partner thing is
Mhm.
because since I've left, when you're working in it day to day, you it's not oppressive, but you get bombarded with the message from NICE, from NHS England, that the guidelines are these and stuff has to fit the guidelines and nothing outside the guidelines. And when I've left and I've kind of started to have a bit more of a broader view on things, I've started thinking a bit more laterally about stuff. And you see it with statins,
Mm.
statins are one of the most overprescribed drugs on earth. The drug companies promote them for literally everything these days. And now I'm starting to see it a little bit with the GLP-1s. Not only are they amazing for weight loss, but now there's these spurious offshoot studies that say that they reduce cancer, they reduce dementia, they reduce Alzheimer's, they reduce, and how much of that is true? How much of that is drug companies trying to make it so that actually everybody will end up on a GLP-1? And so that's kind of where that was coming from. And I've also seen things like, and I've looked into it just out of purely. I've had more time since I've retired to look at stuff out of interest
Mm.
than I ever did before. So now I look at things like testosterone deficiency in men. That's quite a common thing on social media.
Yep, very
Um,
big.
yeah, and if you look at testosterone levels in men now, on average, they are miles lower than they were 50 years ago. And rather than the people triggering testosterone replacement, they've just reduced the reference ranges to say, oh, you're still normal, even though you've got testosterone that would have been classed as abnormal 50 years ago.
Mm.
And I look and I think, well, is this going to be something that in 30 years' time we look back and men struggle to get testosterone replacement, women have hormone replacement, and we would think it would be barbaric not to offer it them. So in 20 years, are we going to look back at this point in history and think, well, is it barbaric that we're not looking at it a little bit differently, that type of stuff? But, it carries all the endocrinology things and it carries the whole stigma of steroids and all the rest of it, when
Mm.
even just in small doses, it can be used to replace testosterone. So that whole thing around how much is drug company, how much is nice, how much is guidance that influences our decision making is of real interest to me now that I'm out of it and I'm not in any way influenced like that. Do you see what I'm trying
Yeah.
to get at?
Yeah, no, I understand. Yeah, no, definitely when it comes to the anti-obesity medications, GLP-1s and GLP-1 GIP, the kind of impact it's having on other conditions, let's say obstructive sleep apnea, heart failure, Alzheimer's, the various different offshoot studies that they've been doing. That's probably true, but it's because of the impact that weight has.
Mm,
When you look at how dangerous increased weight is on health, like I don't think there's an appreciation within society as to just how negative it can be, and so we do need to support people to reduce weight. But I think the key is that those studies that they're looking at the kind of end outcome once you've achieved the weight loss. My worry is that when we know that when you come off these injections, weight regain is quick and is significant, and so we should be looking at the impact of that after it. So there's no point just seeing them, let's say, at 1, 2 years post treatment. We need to have trials that are longer, that look at the likelihood of weight being, still off, so the durability of that weight loss, and then that's going to show you what the long-term health impacts are of that. So yeah, my worry that if we just utilize these as kind of just simple solutions, just like as an anti-obesity solution, and not really, you know, ensure that we're supporting them from a lifestyle perspective. So instead, these should be like a catalyst
Mm.
where they support someone to just speed up and accelerate that weight loss because it is really challenging. The body has a lot of natural mechanisms to prevent you from losing weight. If that can help to overcome that element, but we ensure that we provide all the other lifestyle supports that you must, then we're going to hopefully see some benefit from this.
Mm.
If they're just given out and done at scale and done at speed, in the same way that we've tried to medicate low mood, and now 1 in 5 people in the population, adult population, are on antidepressants.
Mm.
Like, I don't think we've solved depression by just giving them out. Like, as far as I can see, it doesn't seem to have been fixed. So we
No.
won't solve obesity by just giving these injections out. They are merely a tool that is part, really a small part of a wider piece of work that we need to do, both through policy and through kind of health, implementation.
For sure. It's such a difficult thing to unpick as well. I mean,
Oh yeah.
for those people listening that aren't doctors, these drugs, one of the main ways they work is that essentially they slow, correct me if I'm wrong, Hussein, but effectively they slow the ability of the stomach to move food through it. So you feel quicker very quickly. And they also trigger the brain to think it's full soon. So by doing that, you eat less. And if you eat less, you lose weight.
Yeah,
But
yeah. They support you to consume a significantly reduced calorie diet. Like most people on average are eating between 800 to 1,300 calories, and they help to switch off the kind of that food noise that you
Mm.
would have heard otherwise, because naturally only 30% of people are able to maintain a 30% calorie deficit for longer than 6 weeks. So what this does is it enables you to maintain that for, far longer without having the noise in your head saying, "I'm starving, we need to eat." So
Yeah.
that's the
But
key.
if
It
you
also
if
does things
you're
on insulin as well as glucagon and those kind of elements, but that's kind of the key driver of the weight loss.
yeah, and it increases your metabolic rate by, it increases your
Yeah, a
resting
little bit,
heart
yeah.
rate and all this stuff. But if your daily calorie intake reduces to 800 to 1300 calories, but you're still eating Cadbury's dairy milk for that full time, and that is where your calories are coming from. When you remove the brakes by stopping the GLP-1s and you start consuming more of your dairy milk, you're going to put your weight back on, aren't you? So,
Exactly, yeah, yeah. If the diet hasn't changed, if your physical activity levels haven't changed, then the weight's going to go back on, and there's three reasons. One is the body's survival response. When it's lost a significant amount of weight, it want to go back to the set point, like the weight that you've been at previously for a number of years. The other is that we produce GLP-1. This is a naturally occurring hormone, and when you have anything outside of the body added in, then that will naturally push down your own internal release. So there's one theory which was published in JAMA, which stated that there may be an instance where after you remove this exogenous GLP-1, the GLP-1 that you're injecting, it takes time for the body to start producing the levels that it used to, because it's had so many months where it's
mm,
been a bit dormant because it hasn't needed to produce its own.
mm,
And then the final one is that there's a belief that you may be overstimulating the pancreas, leading to beta cell malfunction and your pancreas being less able to control your blood sugars. So, yeah, there's various different factors which we believe may be resulting in this quick weight regain. Because speaking to patients, when they do stop their injection, those weeks afterwards are really challenging. They feel like the food noise is even louder than it was before they
mm.
started the injection. And so it can be really challenging. And some patients have mentioned that it feels like torture. They wake up in the morning and the head is on fire with severe appetite. Some of them said that the appetite's so severe that they vomit, the
Wow.
first thing in the morning, because it's too much to cope with. And so there is sometimes some challenge in supporting people off these injections because of that sort of severe response that they get.
Wow. Yeah, I mean, for a podcast that talks about entrepreneurship and business, this has been wonderful for me to actually talk about something that I feel comfortable talking about, because
Mhm.
it's got a little bit of experience in medicine, I suppose. But for you, what's the what does your future look like? And that's a loaded question because it can all change tomorrow. But
Mm.
where do you think you're headed, and what are your aspirations for the next couple of years?
Yeah, so like over the last 8, 9 years, I've really worked hard to build like financial security, maintaining again that lean lifestyle that enables me to kind of stretch my legs in a way. And I do quite a bit of volunteer work already, which that's only really achieved because I've built up that financial security by investing in various things and trying to build up a portfolio. So my focus and my real aim is genuinely to support more people to take ownership of their own health. I really want to shift the narrative from having to go to your doctor to be guided to one where the clinician is there to support you and you are there to support your own health, if that makes sense. So, like, I'm working with various charities, for example, like Park Run and Sport in Mind, and I'm just looking to one, upskill and train healthcare professionals, and two, empower and activate patients to be better advocates for their own health. I want them to be entering appointments knowing kind of what they want to aim for, what they can access, and how they can really pull their own levers of health to get the most out of it. Because
Mm.
for many, they're unaware of the potential things that they can do, and it's always great, I think, to support someone to do that for themselves.
Well, that sounds like an absolutely wonderful mission to be on. So I can only wish you all the very best of luck with that. If there is a demand for you to come back and talk more health stuff, would you give me the pleasure of being a guest again?
Yeah, of course, of course. We could go deeper into the anti-obesity medicine. That's very much the topical area at the moment. But yeah, no, I'd love to.
Yeah, that's absolutely wonderful. It's been an absolute pleasure having you on, Hussein. Thank you so much for your time.
Thank you.
Oh, before we go, sorry, where can people find you?
Oh, so they can find me on Instagram. My handle is Iron Doctor HAZ, or on LinkedIn. Just if you just type in my name, Hussain Al-Zabaidi, you will find me there.
Wonderful. I'll put those things in the show notes. But again, thanks very much, Hussein. Lovely to speak to you.
Thank you. Take care.